Respected senior doctors and friends, at the outset I thank the Exaltus Pharma for arranging a nice CME and one of the important topics and a very good molecule in the management of resistant hypertension, a chronic kidney disease and heart failure, hydralazine and dihydralazine. In the next few minutes, I would like to talk on hypertension, which is a leading cause of the morbidity and mortality, hydralazine and dihydralazine as a potent vasodilator, and their role in the management of resistant hypertension, CKD, and heart failure, and the end, few take-home messages. See, hypertension is the #1 killer in the world. It's a very leading cause of morbidity and the mortality. And if you see the prevalence in India, at least 1 in 4 adults in India have the hypertension. See, in India, nearly 40 to 45 crores of Indians are having the hypertension. And if you see the global prevalence, that is also very high. Hypertension is the world's leading risk factor for cardiovascular diseases. That includes your ischemic heart disease, heart failure, TIA, cerebrovascular diseases, peripheral vascular diseases, and also CKD, and left untreated, and important cause for the death also. So 70% of the burden of morbidity and the mortality worldwide is due to the hypertension, where the systolic blood pressure is more than 140. So the goals of the treatment, you all know that we should keep the blood sugars below 140/90 in all the individuals. And if you reach a target of 130/80, that is much more better not to have the increased morbidity and the mortality. So it is recommended that the first objective of the treatment should be to lower the blood pressure less than 130/80 millimeters of mercury in all the patients, irrespective of the age. A major goal of hypertension treatment is to prevent or ameliorate injury to T target organs, including the heart, kidneys, and the brain. So by controlling the blood pressure to reaching the blood pressure at your goals, and definitely we can avoid congestive heart failure, we can avoid ischemic heart disease, CKD, and also different CVAs. So in the management of the hypertension, hydralazine and dihydralazine is a good vasodilators for treating the hypertension. If you see the molecules, it is the collagen derivatives. Condensed heterocycles were investigated, synthesized in the early 50s. It is a old molecule. Best known member of this class series are these two, hydralazine and dihydralazine. They are the potent vasodilators. Mechanism of the action, direct vasodilation. So they relax the blood vessels and increases the supply of the blood and oxygen to the heart. So they reduces the workload, thereby reducing the blood pressure. On the other hand, they dilate the vessels by increasing the nitric oxide, which is a potent vasodilator. So they increases your vascular endothelial integrity, and then they reduce the blood pressure. And if you see the dihydralazine, which is our molecule eprizal, here it inhibits IP3. IP3 is inositol triphosphate. So that prevents the calcium-induced contraction. So it improves the blood pressure reduction by increasing the vasodilatation. On the other hand, it also vasodilatation by stimulating the nitric oxide, which is a potent vasodilator, so that by these two ways it reduces the blood pressure. And one way it inhibits the inositol triphosphate, and the other way it improves the nitric oxide, which is a potent vasodilator in the vessels. And if you see the PK, pharmacodynamics, kinetics and the pharmacodynamics, dihydralazine is rapidly absorbed in about 50 to 90%, and good plasma binding protein activity will be there, and about 10 to 15% of the dihydralazine in the plasma is metabolized to hydralazine, and of course it is not a dialysate, and the renal clearance is unavailable for unchanged hydralazine, and there is no significant differences, either pharmacokinetics or pharmacodynamics, between these hydralazine and dihydralazine. See, the eprizal is the dihydralazine tablets. It is available in the form of the 25 milligrams and effectively treats the essential hypertension. It is not the initial agent to be added, but it is definitely an agent to be added in all the resistant hypertension when your routine antihypertensive drugs like your ACE inhibitors, ARBs, calcium channel blockers, diuretics, or your beta blockers are not able to control the blood pressure. Then definitely there is a role of hydralazine as a potent vasodilator in the management of resistant hypertension. And the fellows in the CKD, so definitely when the creatinine level is 4.5 or 5, your hands are tied in using the ACE inhibitors or ARBs. We use only the diuretics like the loop diuretics, and we use the calcium channel blockers, and we may use the beta blockers. And then the hydralazine is also a potent vasodilator. Is a good place to be used in all the cases of the CKD with very high blood pressures. And of course, if the patient is with the heart failure, so definitely you need a vasodilator and also a nitrate, so that this combination is also there, the Eprazole plus in the management of the IHB. Pregnancy, we use the labetalol. It's a combined alpha and beta blocker, and we use alpha methyl alpha, and then even then the blood pressure is very high, especially in the eclampsias and preeclampsias. So there is a big role to use the direct vasodilator like Eprazole, that is our dihydralazine. And at the same time, you should know the some contraindications also. So the allergy, idiopathic or drug-induced lupus, aortic aneurysms, stenotic lesions like the cardiac valvular stenosis, either mitral stenosis or aortic stenosis, hypertrophic cardiomyopathies, pulmonary hypertension. So these are the definite contraindications to use it, and you have to remember the stenotic lesions and the cardiomyopathy, especially hypertrophic cardiomyopathies, to use these hydralazine. Otherwise, you can safely use in all other conditions. So this is the resistant hypertension. You know, by this time you know what is the definition of the resistant hypertension. Resistant hypertension means the person's blood pressure is not under control in spite of the 3 antihypertensives you have used at the maximum tolerable dosages. So as I told you, the frequent drugs, initial drugs to be used in all the population is A, B, C, D. A stands for ACE inhibitors, ARBs, and B stands for the beta blockers, C stands for the calcium channel blockers, and D stands for the diuretics. So initially we use the ROS blockers like your telmisartan, and calcium channel blocker, either amlodipine or cilindipine, and diuretic like your hydrochlorothiazide or chlorothalidone, or the loop diuretics provided if the creatinine level is more than the 2 or 2.5. So in spite of these 3 drugs, when the blood pressure is still 140/90, definitely resistant hypertension means in spite of these 3 tablets, the blood pressure will be 160/100 or 180/100. Then you can use mineralocorticoid receptor antagonist like your spironolactone or the phenyrenone. But one thing is very clear, that when you are using the spironolactone, which is a potassium sparing diuretic, and also with the RAS blockers, the chances of hyperkalemia will be very high. So one should screen for the potassium levels at least once in a month or once in 2 months to check the hyperkalemia. Otherwise, hyperkalemia is a big killer to initiate the arrhythmias and sudden cardiac deaths. And then the beta blockers, vasodilator beta blockers are preferable here, like your carvedilol, bisoprolol, and nebuvolol. We can use these drugs as a beta blockers. But one thing is very clear, that when you are using the beta blocker, please respect the pulse rate. Once the pulse rate is less than the 50, that means the patient is going into the bradycardia, and definitely the beta blocker dose has to be reduced, or sometimes you have to stop using the beta blockers. And then even then the blood pressure is not under good control, then this is a good molecule to add, that is the hydralazine. See, nowadays we are seeing more of the resistant hypertension in the society for the simple reason that we are getting the hypertension at a younger age. Earlier, the average age to get the hypertension is 40 plus or the 50 plus. Now even at the intermediate level or even at the professional level, lot of the people's blood pressure is 140/90. So that means they are hypertensive at the age of 19 or the 20, less than the 20 years, and by 30 or 35 years, they are becoming the resistant hypertension. So the blood pressure is not under control in spite of the 3 or the 4 drugs. So definitely there is a role of the hydralazine to use on these in patients. But one thing is very clear, it should not be used in the stenotic lesions and hypertrophic cardiomyopathies. Di-hydralazine shows a very effective reduction of the blood pressure. I told you how it reduces the blood pressure. On one hand, it improves your nitric oxide. On the other hand, it reduces the calcium intake. So 31 patients with moderate and severe essential hypertension treated with the di-hydralazine. After 1 month and after 6 months, the blood pressure come down to 95. The diastolic blood pressure to reach the 95. And also there is a reduction of 16/11 millimeters of mercury with this di-hydralazine, which is a good reduction as far as our blood pressure reductions is concerned. What about the role in the CKD? See, the CKD, I already told you several times that CKD hypertension is a very common. Hypertension can cause CKD, or CKD can cause hypertension. So hypertension can be a cause or an effect of the CKD. For example, what will happen when the blood pressure is very high? So systemic hypertension, obviously it damages the kidney, it causes the kidney injury. So in 4 ways, how it injures the kidney: one by the vasculature, then the glomerulus, then the tubule and interstitium. So these four are the parts of your glomerulus or the kidney. So vasculature, because of the high blood pressure, so obviously there will be the endothelial dysfunction, so that leads to the CKD. In the same way, when there is intraglomerular hypertension in the glomerulus, so that causes glomerular hypertrophy, your podocytes disturbances, your glomerular basement membrane thickening, that leads to the CKD. When the high the blood pressure, the tubular damage. So once the tubular damage, again the reason for the CKD to be started. And then the interstitium inflammation and the oxidative stress. All these four organs or the four subsets of your kidney will be damaged in the presence of the high blood pressure. So that is the CKD. So the CKD will cause arterial sclerosis, glomerulosclerosis, tubular atrophy, and interstitial fibrosis. Finally, end-stage renal disease. So a persistent hypertensive state can cause the progressive loss of the renal function and nephron mass that culminates in the end-stage renal disease. See now the increased risk of the ESRD in patients with the resistant hypertension. See here, the 32% increased risk of developing the ESRD in patients with the resistant hypertension as compared to the patients with the non-resistant hypertension. So if you see the resistant hypertension, the ESRD, more and more people will go into the ESRD. Now you know that the three common causes to cause the ESRD in Indian population is hypertension, diabetes, and chronic glomerulonephritis. So hypertension and diabetes are the very common etiological factors. With a common etiological factor, it's a deadly duo. So that is the reason in India, the people who are getting the dialysis or who are posted for the renal transplantation, either severely hypertensive or uncontrolled diabetes or the both. So resistant hypertension is an important cause for your ESRD. Coming to the KDIGO guidelines, a 3-drug combination of the RAS, CCB and diuretic at the recommended dosage is not adequate to control the BP. Additional therapy including the mineralocorticoid receptor antagonist, a long-acting alpha antagonist, a beta blocker can be used along with the hydralazine and dihydralazine. It provides the renal protection in the kidney disease. I told you how it protects the kidneys. See the hydralazine molecule mechanism of the action kidney disease, DNA methylation, anti-inflammatory and antioxidation. See, antioxidation, anti-inflammatory and DNA methylation may contribute to the renoprotective effects of the hydralazine. So that is the reason hydralazine is a good renoprotective drug. Di-hydralazine, the dosage for the treating the hypertension. Now the dose, there is about 25 milligrams to the 200 milligrams daily. See the initial dose, each tablet is about 25 milligrams. You have to give thrice a day. So a TAD dosage. So after breakfast, after lunch, after dinner. Depending on the decrease in the blood pressure, the dose may gradually increase up to the 200 to 300 milligrams per day. This is the most practical point. In all the hypertensive patients, whenever you start with the low dosages, you have to uptitrate the dose. So don't be happy with the 40 milligrams of telmisartan. When the blood pressure is moving up, so when the blood pressure systolic is 160, 150, you uptitrate the telmisartan dose to the 80 milligrams or 120 milligrams. In the same way, when you start with the amlodipine 5 milligrams, or the 2.5 milligrams, if you are not happy, that means the BP is much higher, you can go up to the 10 milligrams, but see that whether the fellow is having any pedal edema or there or not, or any vascular headache is there or not, otherwise you can increase the dose of the amlodipine. In the same way, the diuretics also. So all the dosages, whatever you start at the low dosages and go slow, and slowly you have to uptitrate the dosages. In the same way, here, this hydralazine also, even though you start with 25 milligrams TID, don't be happy with this dose. You can uptitrate to the doses of the 200 milligrams to the 300 milligrams. See, without establishing the vasodilator status, the daily dose of the 100 milligrams should not be exceeded. The tablet should be taken with the water. The medicine is suitable for the long-term therapy. No side effects with the long-term therapy. See, what about the combination? See, the hydralazine and isosorbate dinitrate. See, the isosorbate dinitrate we often use in the management of ischemic heart disease and in the heart failures. See, agree with me that heart failure is a very big disease in the society because our people are living longer period. Now, lot of the people, the geriatric population is there. So they are living with the hypertension history of 40 years, the hypertension or diabetic history of 50 years, or ischemic disease history of about 20 years or 30 years. So obviously at the end of their life, maybe at the 70 plus or 75 plus or 80 plus, so definitely they will have pedal edema, they will have orthopnea, they will have PND, they will have the intrajugular reflux, etc. And your clinical diagnosis is the heart failure. So the 4 or 5 important reasons to cause heart failure in our Indian patients are: number 1, ischemic heart disease; number 2, diabetes; number 3, hypertension; number 4, alcoholism; number 5, anemia; and then maybe the postpartum cardiomyopathy or viral myocarditis, etc., or inflammatory. So these 3 important reasons to cause heart failure in Indian population are ischemic heart disease, diabetes, and hypertension. You all agree with me that ischemic heart disease, diabetes, and hypertension are very, very high numbers in India. So that is the reason, as the people are geriatric, more and more geriatric, so there is higher chances of getting the heart failure. So now the heart failure is a complex clinical syndrome that underlies the inability of the heart to perform the circulatory function. So there is a systolic function to pump the blood and also a diastolic function to fill the blood. So there is a pump failure, there is a filling failure. When the pump failure is there, you consider the systolic failure. When the filling failure is there, it is a diastolic failure. So it is due to a structural and a functional abnormality of the heart that results in the elevated intracardiac pressures and the inadequate cardiac output at rest or during the exercises. So if you see the global scenario, so very high because all over the world, the people are more and more geriatric. What about our Indian scenario? Same thing here. Here the prevalence of the heart failure also ranges from about 1.3 to 4.6 million people. You need not remember the figures, but you should understand that heart failure is a very, very common disease in our society. And annual incidence is also increasing like anything. So once you means that it is an heart failure, you need to use 4 or 5 drugs. So there are the 4 pillars. Now the 5th pillar also added in the management of the heart failure. One pillar is the ACE or ARB or ARNI. The second pillar is your beta blockers, that is the vasodilator beta blockers. And the third pillar is the mineralocorticoid receptor antagonist. And the 4th pillar, your diabetic drug, dapagliflozin. And the 5th pillar is Versiogut, which improves your nitric oxide content in the myocardium. So this is how you have to treat the heart failure nowadays. There is no role of the digoxin at this juncture unless the heart failure is due to the rheumatic heart disease. When the heart failure is due to the IHD or the heart failure is due to the diabetes or due to the hypertension or due to the postpartum myocarditis or if it's a viral myocarditis, there is no role of the digoxin. You see, it is associated with a shorter life expectancy. Once the diagnosis of the heart failure means counting the years or the months. So shorter life expectancy. Once the heart failure means frequent hospitalizations. Once the diagnosis of heart failure means the poor quality of the life. All these can be improved with a good understanding of the pathophysiology of the heart failure and by providing the good drugs. As I told you, the 4 pillars or the 5 pillar drugs in all the population as and when required. So definitely we can give good quality of the life to this heart failure population. So heart failure management means not by the cardiologist always. It should be by the general practitioners and all the specialties, because the number of the heart failure people in the society is very, very high and it's very difficult. Only the cardiologist will treat the heart failure because they are very busy with the stents and the angiograms. Mortality and the readmissions risk increases the Indian hospitalized heart failure population. So hospitalizations are very, very common. You see the numbers. 83% patients are hospitalized at least once in a lifetime. Once admitted for the hospitalization in the ICU means they cost about 2 lakhs to 3 lakhs. 43% patients are hospitalized at least 4 times. And 30% of patients are readmitted within the 1 year. So the hospitalizations, readmissions are very, very common with the heart failure diagnosis. See, with the increasing burden of the heart failure and the negative impact on the patient's life, appropriate management makes a huge difference to people living with the heart failure. And I already told you what are all the 4 or 5 pillars of the management of the heart failure. So what are the goals? First goal should be to improve the quality of the life, reduce the mortality, prevent the recurrent hospitalizations, and improve the clinical status and the functional status. So these are all the goals of the treatment with the heart failure. And provided not only these 4 pillars, what is the cause for your heart failure? So if it is the diabetic, control the diabetes very effectively with your insulin or with your OHS. Suppose if the patient is in hypertensive, control the hypertension with the appropriate drugs or the resistant hypertension, you add the Di-Hydralazine. In the same way, when the fellow is is having ischemic heart disease, again you have to use the aspirin, you have to use the clopidogrel, you have to use the high doses of the statins, you have to use the nitrates, etc. in the management of the IHD. So the understanding of the underlying pathophysiology of the heart failure is essential to initiate adequate therapeutic option for each patient. See, this is the big pathophysiology of the heart failure. Already I told you all these things. Poor ventricular function, myocardial damage leads to the heart failure. Whether the systolic failure or the diastolic failure, both the failures. Decrease the stroke volume or the cardiac output. There will be the neurohormonal activation and the sympathetic nervous activation. These two are important pathophysiological mechanisms of the heart failure. One is the RAS activity. The second one is sympathetic nervous activity. For the RAS activity, what is the drug to be used? Either ACE or ARBs or RD. For the sympathetic nervous activity, what the drug to be used? Because these are sympathetically very active, so beta blockers. So when the failure is in the heart failure, the fluid overload will be there, so you have to use the diuretics. So this is how you have to use the different drugs in the management of the heart failure. So the vasodilatory therapy is the treatment of the choice. It helps to reduce the filling pressures and intracardiac blood volume. So examples of the direct acting vasodilators like hydralazine, minoxidil, nitrates, nitroprusside. Out of them, two are very easily used nowadays. Nitrates are available. Now the hydralazine is also available. These two are very frequently available drugs. So you can use these two drugs for the proper management of the heart failure. So the vasodilator combination of the hydralazine and isosorbate dinitrate, the decreased mortality will be seen here. So this is the eprazole plus. Here, the hydralazine molecule is not the 20 milligrams, but 37.5 milligrams, and isosorbate dinitrate is the 20 milligrams tablet. So, combination of these drugs maintains a prolonged state of the vasodilation and improves the bioavailability of the nitric oxide, which is a very, very good vasodilator, thereby maintaining the vascular tone and the cellular redox balance. Now, the clinical evidence. See the effect of the vasodilator therapy in the patients with a chronic CHF. So they have studied against the prozosine. Prozosine is alpha blocker. They have given the prozosine for 180 patients and your hydralazine and isosorbate in 186 patients and placebo for about 200 plus patients. See here. So there will be 34% risk reduction in the mortality was observed by 2 years among the patients treated with the both hydralazine and isosorbate dinitrate versus your prozosine. So same thing here, left ventricular ejection fraction. So that is your stroke volume, or that is your EF. So EF usually heart failure can be divided into 3 groups: REF, PEF, and mid-range ejection fraction. REF means reduced ejection fraction. When the EF is less than 40, we consider as the REF. PEF means preserved ejection fraction. That is your ejection EF is more than 50. So between 40 and the 50, mid-range ejection fraction. That's how the heart failure is divided into the 3 groups. Heart failure REF, heart failure PEF, and heart failure mid-range ejection fraction. See, this is the combination versus your enalapril. So enalapril is a popular ACE inhibitor. So they have used enalapril in 403 versus this combination in about 401 patients. See again here. So increase in the left ventricular ejection fraction after 13 weeks was significantly greater in this combination when compared to the enalapril. So same thing here. So 1050 patients were randomized in the study with the placebo against the placebo. Again, 43% significant improvement was seen with this combination. So the quality of life is also improved with this combination. So the risk of the first heart failure hospitalizations reduced by nearly 40%. So that is a big boon. So we should avoid the hospitalization means we have to use this combination. So the lower rate of the 30 days readmissions within the 1 year admissions also reduced by 41% with this combination. So what do guidelines recommend? So all the guidelines like your American Cardiology Society or the European Society of the Cardiology, in case of the ARNI, ACE or ARB drug intolerance or renal insufficiency, you can use this hydralazine isosorbate dinitrate may be considered to reduce the risk of the death. So initial dose is the 20 milligrams and target dose you can update the dose to BD. So this is heart failure is a progressive and a complex one. So by using this combination, you improves the left ventricular ejection fraction, reduces the mortality in patients with the accelerated heart failure, improves the quality of the life, and reduces the risk of the hospitalizations. So thank you very much for your patient hearing. And if you have any doubts, I will be very happy to